Welcome to Straight Outta Health IT. Getting into health tech is rough, but here's an unfiltered dialogue of healthcare leaders and influencers covering a wide variety of issues affecting healthcare and the health tech industry. And now your host, Christopher Cunny.
Hello, this is Christopher Cunny again, and welcome to another segment of Straight Out of Health IT. Again, I'm very excited today to have as my special guest, Dr. Robert Pearl. This man is an amazing individual and influencer within the healthcare and healthcare technology community. I'm so excited to have him as a guest on the podcast. Let me take a moment just to share with you a few highlights of Dr. Pearl's career. By far not an exhaustive list of his accomplishments, but I think for those of you who do not know who he is, let me share a little bit about him and his background. As a practicing physician, Stanford professor, Forbes.com contributor, and former medical group CEO, Dr. Pearl brings a unique perspective on the business of healthcare and the culture of medicine. He's passionate about helping people understand the interaction and consequences of these forces. Recently named one of modern healthcare's 50 most influential physician leaders, he is also a strong advocate for the power of integrated, prepaid, technologically advanced, and physician-led healthcare delivery services. Dr. Pearl served as the CEO of the Permanente Medical Group and president of the Mid-Atlantic Permanente Medical Group, which at the time of his tenure was the nation's largest medical group comprising over 9,000 physicians, 35,000 staff members, and 4 million Kaiser Permanente members on the West and East Coast. In 2017, he authored the Washington Post bestseller, Mistreated: Why We Think We're Getting Good at Healthcare and Why We're Usually Wrong. His book offered a roadmap for transforming American healthcare. And interesting enough, all proceeds from that book went to Doctors Without Borders. I sincerely encourage all of you to take a moment to download the book on Audible or purchase it online. I think you'll find his perspective on healthcare and his ideas around transforming the industry of value. Dr. Pearl also serves as a clinical professor of plastic surgery at Stanford Medical School of Medicine and is on the faculty of Stanford Graduate School of Business, where he teaches courses on strategy, leadership, and lectures on information technology and healthcare policy. Since 2013, he's also been a regular contributor for Forbes, covering the business of healthcare and culture of medicine. And he's also been featured on programs such as CBS This Morning, CNBC, NPR, and in Time and USA Today and Bloomberg News. He is also a board-certified plastic and reconstructive surgeon, having received his medical degree from Yale University School of Medicine and his residency in plastic and reconstructive surgery at Stanford University. Man, welcome, Dr. Pearl, to the program. I am so excited to have you, and what an amazing career you've had.
Thank you, Christopher. And as we said before the show, let me add that I have a recent book called Uncaring: How the Culture of Medicine Kills Doctors and Patients. Once again, all the proceeds go to Doctors Without Borders. And I wrote it because it's the sort of the other snake on the caduceus. That symbol of medicine with the two snakes around the single staff is the culture of medicine and the system of medicine. And any of the listeners who want more information can go to the website, robertpearlmd.com.
That sounds great. Well, we're definitely going to have to delve into some of the topics in that book as well. And again, I'm so glad to have you on the show today. I want to start with just a very simple question for you, Dr. Pearl, and that is, why and how did you get into medicine? What prompted you to become a doctor?
Across my entire career, Christopher, serendipity has played a huge role. I went to college to become a university professor. And when my hero, the chairman of the philosophy department, Hugo Bideau, didn't get tenure due to his political beliefs, and by the way, he went on to become the chairman at Reed College, so he was a pretty accomplished individual,
Absolutely.
I decided I wanted to do something that would have no politics, and that would be medicine. I mean,
And little did you know, right?
I was 70 years old. What did I know? It was life and death. I figured, if I wasn't any good, that was okay.
Right.
It was okay, but I could accept it. But I didn't want to ever be in a situation where people were judging me on political views, judging me on other things besides the quality of my work. And I went into medicine because I really thought it would be objective. And of course, I've since discovered that it too is filled with political challenges, innuendo,
Absolutely.
a variety of other forces.
There's a really good book out called The Political Determinants of Health as well, too. So to your point, healthcare is filled with politics and challenges that legislation and policies impact the delivery of care. So I'm sure you'll touch on a little bit of that as well in our conversation today. You're really considered one of the industry's foremost thought leaders in patient engagement and how providers' attitudes and actions, impact the delivery of care. Can you maybe take a few minutes and just kind of expound on that a little bit? In your initial book, your first book, Mistreated, why we think we're getting good healthcare and why we're usually wrong. You kind of touch on those topics. And I'm just curious from your perspective, how is, healthcare being delivered in this country today? And why do you think we're getting it wrong?
So again, I'd like to focus both on the system and the culture. So let me start with the system, which was the book Mistreated. From my perspective, the United States healthcare system is a 19th century cottage industry. It's fragmented, doctors and hospitals scattered across the community. It's paid on a piecemeal basis. We call it fee for service. The more you do, the more you get paid. Whether it's any good or not, that's irrelevant. The technology that uses is left over from the last century, although actually it's from the century before, because believe it or not, the most common way that doctors exchange vital information on patients is the fax machine, an 1834 invention. And there's no one who has the authority anywhere across the United States to make the kinds of changes that are necessary to make the care delivery system become better for patients. As you know, we spend twice as much as almost every other nation per person on healthcare, and our results, according to the Commonwealth Fund, are last. We have the lowest longevity amongst the 12 most industrialized nations, the highest childhood mortality. We have maternal mortality that is not only the highest, it's 4 times as bad as the next highest country, unless you happen to be a Black woman, and then it's 12 times as bad. We have a very broken system. And I wrote that book, as you said, in 2017. It was published 2017. And in 2019, you may remember that the federal government put out a prediction based upon the data available at the time that over the subsequent 10 years, that healthcare costs would rise 5 to 6% each year.
Right.
And I did the math. This is compound interest. It said that over the next 10 years, healthcare costs would go up 2.5 trillion. That's with a T.
Oh my God.
A year, per year. And I said, and by the way, that's the same healthcare. That wasn't better healthcare. It was just the same healthcare.
Right.
I said, imagine if we use that for social determinants of health. Imagine if we use that for racial disparities. Imagine if we use that for chronic disease. I could give you 10 ways we could use that money better. And I waited for some national organization, some group.
Some nugget, some magic,
to say, this is absurd.
Exactly.
Let's use it differently.
Right.
And nothing happened. And that's what told me that there was another factor besides this broken system. And that's why I wrote the second book, Uncaring: How the Culture of Medicine Kills Doctors and Patients, because it says that in the culture of medicine, we are in denial about the problems. We tell ourselves the care we give is great. We tell ourselves we're the best in the world, despite data showing that there's not a shred of evidence that we are the leader, except in being the most expensive and inefficient.
Exactly. It's interesting. You said a couple of things you said earlier in your commentary about the way healthcare is delivered in this country today. In another life, I was a CIO. I'm actually a recovering CIO now. But I was talking to my chief medical information officer one day over lunch or cocktails or something. And he had mentioned he was a third generation or fourth generation doctor or physician. And he came across his great-great-grandfather's medical journal. And his great-great-grandfather practiced medicine during the Civil War. And what he said was, he was reviewing his memoirs, and what came to mind, or what was really shocking to him, was he realized that we were practicing medicine basically the same way that his great-great-grandfather was practicing during the Civil War, that fundamentally nothing has really changed. Medicines have gotten better, maybe certain procedures have gotten better, but the fundamental practice of healthcare hadn't changed in almost 150 years. And to your point, it's really shocking that despite all the data that's out there that shows the challenges and issues we have in the delivery of care in this country in particular, but across the world as a whole, that we haven't figured out better ways to deliver care and provide more equitable care across the various demographics that exist in this country. And again, if you go outside the four walls, the borders of this country, to other cultures and other communities, in some cases, they found a better way to do it, a cheaper way to do it, a more consistent way to do it. And whether you believe in socialized medicine or fee-for-service medicine or whatever, we still have to come up with a smarter way of driving costs out of the delivery of care and trying to provide care as best we can, the same or equally the same to all populations.
I concur. I do think that we saw a renaissance in healthcare, I think, particularly driven by medications in the second half of the 20th century.
Mm-hmm.
And we did see a significant prolongation of life.
Right.
We had drugs to prevent heart disease. We had tests to both prevent and find cancer earlier in the course. And we saw an improvement in clinical outcomes for people. But in the 21st century, you're absolutely right. Longevity has not gone up for 2 decades, despite this massive increase in cost. And I believe that the system we have today, which is left over from the last century, is just not capable of handling the kinds of problems patients have today. If you go back to the time of your friend's father or grandfather, you broke an arm, cast was set. You had appendicitis, appendix was taken out. It was a simpler time, not just from a society perspective, but disease perspective. Now people have 4, 5, 6 chronic disease. There are multiple medications. It just can't be done when every doctor works alone and there's no collaboration and coordination.
Right.
It can't be paid on fee-for-service. It has to be paid on a prepaid type basis, capitation, where a group of doctors receive a payment for a population of patients, starts to align those incentives so that physicians see it in their interest to maximize prevention, avoid complications from chronic disease. You start to elevate primary care, the doctors who prevent the arteries to the heart from being blocked in the first place, rather than just the cardiologist or cardiac surgeon who unblocks them when they become occluded.
Right.
And in that context, you embrace I'll call the right technology, the technology that's capable of raising quality and lowering costs. And almost none of that exists in American medicine today.
So let's drill down into that a little bit more. And I always ask the 5 whys. We understand the challenges that exist in healthcare today. I'm going to challenge you. Why is it such a challenge for American healthcare to move away from episodic care to more accountable care, more proactive driven medicine? What's the root cause of that? And why is it such a challenge to switch or move in a different direction?
Well, I have to give you 2 answers. Remember, this is 20% of the world's largest gross domestic product. So
Sure.
1 why may not be the answer, but it's both the system and the culture. It's
Okay.
the system in that when you structure healthcare in a fee-for-service type way and you pay people based upon volume, what you're going to get is volume.
Right.
But also, when you have a culture that elevates individual physician autonomy, that has a hierarchy left over from the past, that puts physicians above everyone else, that puts specialists above primary care. And this is in a hierarchical fashion. It's not driven by insurers or other people. It's
Sure.
inside the profession. Every medical student knows it. When you have those things, you also create these inefficiencies because you stop having teamwork. You stop having groups of people each bringing their expertise together. Any technology that levels the playing field is disregarded
Right.
in place of the technology that elevates the doctor more. And all of this doesn't make any sense in the context of healthcare today and the problems that patients face.
So is it safe to say there's almost a godlike complex that, physicians espouse to in that delivery of care? To your point, you've got primary care physicians that are kind of the lower tier, for lack of a better term. I don't mean that directly, but just in terms of hierarchical levels, primary care, and then you have your specialists, and then you have your surgeons, and et cetera, et cetera. Is it a mindset that physicians have? And how do we change that mindset?
Yeah, I don't think it's a godlike complex or physician-specific mindset. Sir Michael Marmot in England, a sociologist, has done a lot of studies on hierarchies. And hierarchies are the reality of the world. Groups and individuals want to be elevated for esteem, for respect. We pay people to a large extent coming out of those hierarchies. So there's a systemic reason that sits in place on top of the other drivers. I'll say it, the more psychological ones that
Sure.
sit in play. And we know that as you fall down a hierarchy, you become dissatisfied, unfulfilled, fatigue. These are the symptoms that we call burnout. And they're certainly prevalent in medicine today. So it's somewhat, I would call it almost inevitable. The problem is that we're talking in this context about human life. And that kind of hierarchy that's traditionally been in place doesn't make sense.
Exactly.
It may make sense in other arenas, but in healthcare, we need teams, we need collaboration, we need coordination, we need valuing everyone's contribution, and that is not what occurs today. There's data. Stanford and Harvard worked together actually on a study, and they showed that adding 10 primary care physicians improved longevity by 2.5 times more than adding 10 specialists. And who do we train in the United States today? Who are we adding continually? More specialists.
Right.
Where do we have the greatest efficiency? Primary care. Who do we elevate? The specialists. Who do we look down upon relative to residency choices? The primary care physician. It shouldn't come as any surprise that the current culture of medicine, we get what we are designed to accomplish. There's a saying in business schools, tell me your incentives, tell me your structure, what you value, and I will tell you the outcomes you're going to get. And we get the outcomes that you would expect, given how broken both the system is and how problematic the culture is.
So can you give me any examples of any, you don't have to specifically say which organizations unless you wish. Are there some examples of where this is being done right? Where you see, this appreciation of care coordination happening between primary care and specialists and other healthcare professionals. I know you were obviously a leader at Kaiser, and Kaiser is one of those few organizations that I think operates under a capitated model, but correct me if I'm wrong. Is that an example of where we may be moving in the right direction? And again, I don't want to put you on the spot there, but just curious from your perspective.
No problem at all. Yeah. So when I was the CEO in Kaiser Permanente, so Kaiser Permanente has two organizations. There's a Kaiser Insurance, and there's a Permanente, which the delivery system. I was the CEO of the delivery side, and there was a CEO also of the insurance side.
Right.
We went from being sort of, I would call it when I took over, we were sort of good but not great, to being number one of 1,000 programs in quality. We lowered the chances of patients dying from heart disease 30 to 40% below the community around us. We lowered the chance of dying from colon cancer 30 to 40% below the community around us. We lowered the chances of patients dying from AIDS, HIV when they became infected 30 to 40% around the community around us. And we also were able to raise patient satisfaction 20 points above the community around us, physician satisfaction 20 points above the rest of California, and cost 10 to 20% below
That's great.
the competing programs. And we were the leaders in innovating technology. We published an article in Health Affairs about 8 years ago, where I talked about the fact that at that time we were doing 10 million virtual visits a year. This is long before COVID.
Yeah, that was unheard of back then.
Unheard of.
Exactly.
Yeah. And none of this could have happened without having a capitated, prepaid type methodology, without having the kind of integration, coordination, and collaboration, and without having a defined leadership structure for which I was the CEO and able to make things happen. I'll give you an example.
Sure.
So if a patient's seeing a primary care physician and the patient has a problem where the primary care physician feels as though he or she needs some expertise, some additional information from a specialist, what happens in most places? In most places, the patient gets told, go home and call the specialist office, or maybe the doctor communicates and the office will call the person back. It'll be days before they get seen.
Exactly.
We brought in the specialist using video so that the primary care physician and the specialist could be there with the patient, and we resolved 40 to 50% of the problems immediately, right there and right then, without having any follow-up. I just published an article in the Harvard Business Review on why telemedicine is far more than a doctor and a patient. It requires this integrated care delivery system and this obsession with raising quality, raising patient satisfaction, raising physician satisfaction, and lowering the cost. Go back 20 years ago, the expression was quality, service, cost, pick any two.
Right.
Now we can have all three.
Absolutely.
We don't. But we don't, because in medicine, we have yet to embrace what is possible because the system is broken and the culture is problematic.
Well, thanks for sharing that, and I commend you on being at the forefront of the transformation of healthcare in this country. And I'm just curious, was a lot of that driven or enabled, I should say, by your adoption of these technologies? Like Kaiser was one of the first organizations to adopt an electronic health record system, across its healthcare providers. Obviously, you were one of the first organizations to adopt and leverage effectively telemedicine as a platform. If those things did not exist today, could you have done this, accomplished those successes in the delivery of care model without the use of technology?
No, technology was a major driving of the improvement. So how did we become number one of 1,000 programs across the U.S. in quality? It was the electronic health record. But it's the electronic health record in the context of a fully integrated medical group. Because otherwise, every doctor has their own EHR and it doesn't connect. There's no interoperability, and the information can't be relied upon.
Right, or siloed.
You know that the patient has a problem, even if it's not in your expertise. I could check a patient's blood pressure and say it's out of line and get back to the primary care physician. I might not know the most current way to treat it, but I can get that expertise. I can write the prescription if that's what the doctor tells me, or I can have the primary care physician, call the patient. It's identifying and solving the problem immediately. It's not possible without an EHR. So we went from being good to being great, to being number one in the country. Same with satisfaction. If you have the ability to send an email, to be able to text a message, to be able to arrange a video visit. As you said, I was the CEO on both coasts. I was responsible for 12,000 physicians by the end, actually, and responsible for close to 10 million people. So in the Mid-Atlantic, at night, we had, or actually 24 hours a day, but at night, when everyone else had closed their offices, we had a physician, these were ER physicians actually, in a telephone center. And if a parent was taking care, had a child, let's say a 4-year-old with 103 fever, and it was midnight, who would they call in most situations, in most communities? We had a doctor right there and then, and the physician would look at the child using video. If the kid was lying there limp on the ground, the physician would say, get your child to the ER as fast as you can. I'll call ahead and they'll be ready for you and they'll start the antibiotic because your child probably has meningitis. The kid's riding his bike around, laughing and having a good time.
Sure.
Go to bed and don't worry about it. That's the kind of opportunity that exists. And what's most interesting is it takes out a lot of cost while adding quality and better service. We know that going to the ER is 12 times as expensive as seeing a personal primary care physician.
That's
and
right.
Yet for 12 hours every night, for more than half of the week, by the time you factor in the weekends, that's what we tell people to do.
Exactly.
It's less good care, less satisfying.
That's right.
And certainly more expensive. We can do a lot better. We just have not made the changes that are needed, both in terms of the system and the culture.
Great perspective on that. And as I'm listening to you share your insights on this, I'm going back to the concept of nature versus nurture, right? And that is, do you teach these concepts while an individual is in medical school so that they can start to appreciate and adopt the need to transform? How do you start to plant the seed for true transformational change and shift that paradigm from the provider being the sole caretaker or in their mindset to one that's much more collaborative? Just curious from your perspective, is that something that should start at the very beginning of the educational phase of the clinician, or at what parts of the process do we introduce these concepts so that we can hopefully move to a better model of the delivery of care?
When you raised the issue of nature versus nurture, I thought you were going to go back to the origins of Kaiser Permanente, because I was the fourth CEO in its, at that time, 60, 70-year history. And I owe a lot of what I did in the 21st century to what Dr. Sidney Garfield started in 1940s, 1950s.
Exactly.
Because Kaiser Permanente started by being capitated. It started by being integrated. It put in place technology in the 1960s. So I was able to build on those advances to stand on the shoulders of those who came before. And to me, that's much of nature. It's built into the genetics, into the structure of who we were inside the Permanente Medical Group. So from that standpoint, I think that it's nature and nurture.
Sure.
But I also would say, to the point that you're making, medical education is totally broken right now.
Right.
I mean, think about it. How do we figure out who to take into medical schools and who to admit to the best residencies? We give physicians these exams. There's a 2-day exam called Step 1. And basically, Step 1 is a test of memory. There's 10,000 or 20,000 arcane facts, 95% of which doctors will never use again. But that's the way to separate people and provide a score. And those who score at the top are the ones who get advanced, and those in the middle or behind aren't. In 2007, a device was created. It's called the iPhone. And on that iPhone sits all of this information. If you happen to be in the Congo River and you encounter a certain unusual disease and you don't know the medication, you can look it up. It's right there and then. Why do we prohibit physicians or physician applicants from bringing iPhones into exams? We should require it and then test them on the ability to apply it. And
Absolutely.
As you say, we should be training people using business school approaches. How do you create highly performing teams? How do you figure out what is the best evidence-based approaches to a particular type of problem? How do you communicate effectively? We know that most patients who leave the doctor's office don't know what they were told. How
Right.
do you expect people to do the right thing when they don't even know exactly what you said? These are the 21st century skills, but culture's always related back 20, 30 years ago. We still teach what was optimal in the 20th century,
Exactly.
except for almost a quarter of the way through the 21st. You're absolutely right. We've got to train people differently, but I think we also have to start leading the way. And that's why I write what I write. It's why I have 2 podcasts on fixing healthcare.
Exactly.
One's there. In order to get that change to happen, it's very hard to ask a new doctor to be the leader of the process.
Right.
Everyone around him or her is still embracing the old way. So I think it's a combination of training the next generation and leading the way, breaking through the snow on their behalf.
Yeah, I'm optimistic too, because that next generation are digital natives. They grew up with the iPhone, the iPad, the Android devices, and they've always used them as a resource for themselves to learn about things, get educated, get information. So I'm encouraged that they will be demanding that these technologies are part of the delivery of care. And the reality of it is the computer, the iPhone, these devices now are clinical devices now. They can be used to treat patients and provide some level of care or provide information that help deliver care. Also wanted to touch real quickly on something you said about, the culture, and the fact that part of, I think, the challenge we have in the industry is when we talk about racial disparities, health disparities in healthcare is the lack of healthcare professionals of diverse backgrounds. The 2000 U.S. Census showed that nearly 12% of African Americans accounted for the population, but they are woefully unrepresented in healthcare in terms of doctors, healthcare specialists, healthcare professionals. And it gets even worse as you start drilling down into the Hispanic community, Asian community, Latino communities as well. I'm just curious about your comments on health disparities, social determinants of health. The reality of it is that culture does have an impact on the delivery of care. And what can we do in this country to start to close those gaps?
I would start with a major part of the culture of medicine is a culture of denial.
Mm-hmm.
And part of a culture of denial, by the way, is quite positive because it's what allows doctors to be heroic. I mean, if you think about, go back to 2020, when the coronavirus comes out of Wuhan across the Pacific,
right.
Doctors go to the ER. They don't know what this virus is. Vaccinations don't exist. There are no medications they can take to treat the disease. And yet they take care of patients every day. When patients can't breathe, they pass breathing tubes through the mouth into the patient's lung, knowing full well that as the tube goes to the vocal cords, the patient will cough, spewing virus in the doctor's face, and they do it anyway.
Right.
And this culture of denial that actually has come across time, having to do with when doctors could offer patients very little, but they couldn't deny, they couldn't accept this inability, and they denied that they had really very limited abilities to treat disease, even to diagnose disease. So this culture of medicine of denial still exists. So that's the first place that I would start.
Sure.
The issue of the causes of these environmental factors on medicine is another good example. As doctors, we think the most important, biggest thing that we do is the prescription pen or the surgical procedure we perform. But what do we know? We know that the social determinants of health are far more powerful, probably 3 times the impact. But we deny that. We say that's not our job. So what's our job? Is our job to keep people healthy? Is our job to minimize death? Well, then that is central to what we do. Gun violence is a great example of that. How do we intervene? Many of the things around mental health is another good example, identifying it, preventing suicides, preventing other issues. So that's one example. But you're raising the one about the racial disparities. And we have the data. We just don't do anything about it. To me, that says we're in denial. What do we know early in the pandemic? We knew that our Black patients were dying 3 times as frequently as white patients. All right. And yet, what do we know? We know that when patients came to the ER, there was a shortage of testing kits. We tested the white patient twice as often as the Black patient.
Exactly.
It made no sense at all, but that's how we see it. And the data is everywhere. Women after mastectomy, we offer white patients reconstruction more than Black patients. We give 30 to 40% less pain medication to Black patients than white patients. All of these things exist. Now, I write in my book, I'm caring a lot about this issue, and I make the point that some of this is biological. Some of this is what we call implicit bias.
Sure.
What we know is that from 20,000 years ago, when someone showed up at the entrance to your cave, you had a split second to decide whether to throw a spear at them or welcome them in. And so we've learned to identify people who look like us, speak like us,
Exactly.
worship the same God as us. That is biological. But what's racist is when we do those things and we don't acknowledge it. We don't even recognize it. And that's where I think technology can offer a tremendous amount. When we order 30% less pain medication, an AI application could ask us, are you sure you want to give this much less medication? Last time you gave more and the time before that more. What is different?
Yeah, what changed? Exactly. What's the difference?
Yeah,
Exactly.
maybe the answer is there is something that's different because they have a spinal cord injury. But most of the time, it's going to be something else. When you don't test someone with a low oxygen for COVID, it should be asking you, why didn't you test this patient? The last one with a O2 of 90 instead of 100, you tested.
That's right.
Those kinds of opportunities are there. And you're absolutely right. What we know is that the racial bias contributes tremendously to medical problems. I saw an estimate today, I don't forget how many billions of dollars more it's going to cost us because we do a poor job in preventive services, early intervention, listening to the patient, applying technology. The list goes on. And in the culture of medicine, we just ignore it.
Exactly. Well, it's amazing. Our time has flown. We literally have less than a minute before the session will be wrapping up. I want to give you an opportunity to give any final thoughts in the next 30, 40 seconds before we have to end this episode. And I thank you so much for being a part of this as well.
Well, thank you very much, Christopher. Let me offer 3 sets of final thoughts. The first to doctors, you work incredibly hard. You're dedicated. You're committed. The system you work in is broken. Don't stop fighting to make positive change happen, but also look inside the culture of medicine and the ways that we as doctors can improve the way that we provide patient care and improve the health of our nation. To the patients out there, remember to speak up. Remember that this is your life. Ask the hard questions. Make sure that you thank physicians when they take steps to put your life ahead of theirs, but don't be afraid to ask about challenges around prevention, opportunities to avoid complications and medical errors, and making certain that throughout your life, your doctor will be with you, including at the very end in your time of greatest need. And to listeners, if you want additional information, you can find it on my website, robertpearlmd.com, and continue to listen to podcasts like this to better understand medicine and understand the role that all of us can play to once again make American healthcare the best in the world. Thank you.
Thank you. Great advice. And once again, I appreciate your time and your leadership in helping to transform our industry. Well, we've got another episode of Straight Out of Health IT in the books. I look forward to continue to provide, hopefully thought-provoking programming for my listeners. And I encourage all of you to share this podcast with your friends, associates, and you can find us on all the major podcast channels. Thanks again. Appreciate your support. Take care and God bless.
Thank you so much for listening to Straight Outta Health IT. We hope you enjoyed today's guest. For more unfiltered dialogue of healthcare leaders and influencers, be sure to tune in next week. For the show notes, transcripts, and resources, please visit Apple Podcasts, Spotify, or your favorite streaming platform. We invite you to give us feedback by reaching out to Christopher Cunny on LinkedIn, just searching for Straight Outta Health IT, and you'll find us. We are constantly having live discussions about diverse topics in the industry.